Welcome back to season 4 of
A Couple of Multiples.
The Reality of Dissociative Identity Disorder. Did you know that according to a recent Harvard study, 93% of people living with DID are initially misdiagnosed by mental health professionals? That's a staggering statistic, and it's exactly why we're here.
This season, we're diving deep into clinical interventions. What actually helps when it comes to recognizing and treating dissociative disorders? Whether you're a mental health provider, a supporter, or someone navigating life with multiplicity, this season is for you.
Thank you for being here. Please share this episode with a friend, your therapist, psychiatrist, or colleague. Together, we can help improve access to accurate diagnoses and effective, compassionate care.
And most importantly, remember that every system is different. What works for one may not work for another, and that's okay. Your journey is valid, your healing is real, and we're so glad you're hanging out with
A Couple of Multiples. Today's episode is brought to you by
Healing Selves Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Healing Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Healing Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid, and Medicare. This episode is brought to you by Donna Earle, a licensed professional counselor and certified clinical trauma professional.
She's the founder of To Life Counseling in Southlake, Texas, where she helps individuals ages 17 and up heal trauma, navigate identity, and reclaim inner peace. Her trauma-informed approach includes EMDR, parts work, strengths-based therapy, TBRI, and CBT.
She's passionate about honoring the resilience of the human spirit, one story at a time.
Welcome to another educational episode with Drew
and Garden System,
A Couple of Multiples.
The Reality of Dissociative Identity Disorder. We are honored to have with us today Dr. Mike Lloyd from the CTAD Clinic over in the UK to discuss the recognition, diagnosis, and treatment of dissociative disorders.
Mike is a consultant clinical psychologist specializing in complex trauma and dissociative disorders. While working in the NHS in both child, adolescent, and adult community settings, Mike started Cheshire Psychology, a small private practice. Since then, Mike has worked as a consultant in the Ministry of Defense, offering mental health support to serving military personnel, and formed the CTAD Clinic, a specialist referral assessment and treatment service for complex trauma and dissociation within the UK. The CTAD Clinic works in partnership with the NHS and has a number of clinical psychologists and psychotherapists offering specialist services.
Mike is a member of the European Society for Trauma and Dissociation, having previously been on the ESTD board. Mike has taught on the ESTD UK Foundation course, as well as with various university doctorate programs for clinical psychology trainees in the Northwest. Mike has presented at many national and international conferences and has published in the field of trauma and dissociation. He set up the clinical base for the CTAD Clinic on the Cheshire countryside in 2021, where he has also established a small rescue center for Muscovy ducks for clinical patients to experience. Mike informed the CTAD Clinic YouTube channel in 2020 to promote education and awareness into dissociation, and which now has over 22,000 subscribers.
Welcome, Dr. Mike Lloyd. We're so happy to have you today.
Thank you. Yeah, well, very, very pleased to be here. This is quite exciting.
Yes, it is. So, spreading awareness and providing education on dissociative identity disorder is so important. So, thank you for coming and sharing all that you know. We are really looking forward to today's conversation.
Yes. So tell us a little bit about yourself and how you came to work with dissociative disorders, particularly dissociative identity disorder.
Okay. I mean, I suppose it's a random thing. So there's absolutely no plan whatsoever for that second bit. But so I'm a clinical psychologist. So I have been since qualifying in 2005, I think, if my memory serves me correctly. So again, never really even planned to be a clinical psychologist. It was something that I was working in obstetrics, gynecology, and pediatrics, and a pediatric nurse and I were sharing a car doing a road trip to a meeting or something. And I noticed there was a psychology textbook on the rear seat of her car. And I said, oh, that's cool. That's exactly the same textbook I had. And she said, oh, it's her daughter, doing an undergraduate. So we just talked about that. And she said, oh, you'd make a really good psychologist. And it's like, I didn't even know what like a clinical psychologist actually did. So I got my degree in psychology, but no one talked about professions. So I just kind of walked into the psychology department at the hospital and said, because I thought that sounded like a fun job, more fun than the one I was doing, which was management stuff. And they just said, oh, you have to go on this course, this 3-year doctorate course. And I thought, oh, God, I have more university time. How do I do that? And they just kind of said, here's the steps to get on training. And I just followed the steps and became a clinical psychologist some years later, but never heard of dissociation. So throughout my undergraduate stuff, and I've also got a master's in medical anthropology, and it's never mentioned. 3-year doctorate in clinical psychology, dissociation not mentioned. Complex trauma not even mentioned. Then I started working in child and adolescent mental health, again, not mentioned anywhere. And then I randomly was looking to get a job in adult services, and I got a couple of days a week. And they said, if you want more time, you have to sort of see this patient. We don't know what's going on. She's got this weird diagnosis. No one knows what to do about it. We're stuck. She's in the system, and someone needs to go in, and we've got a supervisor prepared for you. Are you interested? So I said, hell yeah. Why not? Sounded like a really good thing. It's kind of right up my street. You give me an opportunity, I'll get in on it. The supervisor was Rami Akron, who runs the Pottergate Centre in the UK. So very well known, very well respected guy over here. And he just sort of talked me through it. I met this lady, kind of just, it got stuck in, I suppose. It's like that from that, like within 5 minutes of meeting, something just kind of clicked in my head to say, you need to be doing this work. And I ended up working with her for 7 years and learned so much, and kind of was like scared and excited by the whole thing. And then as that process was going through, I was like, I am never going to stop doing this work. This is the thing for me. I always thought it was pediatrics because I really love working in pediatrics. And this is kind of quite different, but has some similarities. There's, and then, been doing it ever since. I just absolutely just gravitated towards it. Loved doing the work, loved being with that person, and then all the other people that I was working with from then, and then just built and built and built and built, collected people around me. And then sort of 5-6 years ago, formed the thectadclinic because it wasn't being done properly in the NHS, in the health service as we see in the UK. It's like bits here, bits there, but nothing dedicated. And I really wanted to dedicate myself to it, and I just couldn't, working in the job. So I had to leave everything, quit my job, let go of all the the perks and the securities and the safeties of having a really great job, and just started the clinic, went for it.
And that's amazing.
We're so glad you did.
Yes.
A big risk. But I don't know if you've ever seen the Kevin Costner film, Field of Dreams.
Yes.
It's a baseball film. That's been my philosophy throughout all of my work, which is if you build it, they will come. And absolutely. I thought I'll just get it going, get started, see what happens. And we've now got this really great clinic I've got a fantastic team around me, and that's awesome. We're doing the work that we're passionate about.
That's fantastic. And it's so needed, and that's kind of what Drew and I talked about too, is like, we just have to do it. Somebody has to make it. You're right. Like, it's not just the UK, the USA and Australia and all the places. Like, we're seriously lacking in really good education and support. And that's what we want to do here for everyone, is provide that so that, people can get help, because so many people are searching.
Absolutely. I mean, and we see this all the time. I mean, I probably get like probably a request every few days from either the States or Canada or New Zealand or something like that, saying, how can you help me, kind of thing. And they might be in Milwaukee or Auckland or something, and it's like, we're so limited in what we can actually offer overseas. So things like the YouTube channel and all the various different things, and podcasts with you both, I suppose it's just getting the message out there and telling people, take this seriously and listen. And if we don't do this, it ain't going to get done. I suppose that's the point.
Right.
That's right. Yeah.
Yeah. And your YouTube channel is such an amazing resource.
Yeah.
Oh, thank you. Yeah, it's good. That was, again, no plan around that whatsoever. I was just like,
it just happens, right?
Yeah, it kind of happens. So, the person I knew well invited me to do a little interview on her YouTube channel, which was Multiplicity and Me, Jess, and who I'd known for a long, long time, and just kind of got the bug from that. I thought, wow, that's really a lot of fun, and I can talk, so
yeah,
right.
We could talk about this all day for sure.
Yeah.
So, well, it's awesome. So, thinking about, getting more education out there for everybody, a lot of times we notice that, especially as a registered intern myself in Florida now, like, people come in with every diagnosis under the sun but DID, right? So, like, what are some common misdiagnoses clients with DID end up receiving, and why?
Okay. I mean, this is it's a sad question to have to ask, isn't it? Because I always sort of like think in terms of dissociation and diabetes, and we wouldn't be asking this question really for diabetes, but here we are. I mean, the obvious ones are going to be things like depression and anxiety. So, and sometimes PTSD. Often if people are lucky, they'll get the PTSD type stuff. More often than not, we're in the sort of category of like low-key psychotic type diagnoses, maybe schizophrenia, maybe psychosis. Early intervention teams have a lot. Neurological things, so sort of epilepsy and various different stuff, a lot of physical stuff, IBS, things like fibromyalgia, there's the physical concerns, there's sort of the unexplained medical stuff. Personality disorders, so the borderline emotionally unstable personality, schizoaffective disorder, bipolar disorder, and then there's just a range of different things. And you think about the route that people take to get into services like us. They can come from, say, dementia services, they can come from physical health, trauma-based services, and that's not even looking at what's happening with kids. That's just the adults going through the system. So the kids wouldn't get any diagnoses, but you might get like that pathological demand avoidance and things like that, oppositional defiant disorder, because internal parts are pushing rather than accepting, and the randomness. But a lot of people are really reluctant to diagnose kids with things. So it's almost like we'll just kind of give you a holding diagnosis of some sort of developmental disorder. Wait till you're in adult services, and then you move into the personality disorder territories. So people often come to us if they've been through the system, maybe half a dozen different diagnoses, and it's a pattern.
Yeah.
Yeah.
I know there's some things I've noticed, like if people have been in the system for many years, not getting better. And I see things like, oh, they have bipolar. Oh, they have schizophrenia. Like, these are the diagnoses they've had forever and their medication's not working. It's like, maybe we need to rethink this.
Yeah. Or you get the treatment resistant. So you can have like your treatment resistant this or treatment resistant that, because we've been trying this medication for the last 10 years and it's not working. So therefore it's your fault.
Yeah.
Maybe it's not the medication. That's not the issue. Maybe. Or people have had just rounds and rounds and rounds of different therapies and it's not worked.
Yeah.
And you're like, again, that comes down to then you get what's in this country is called a heart sync patient, which is as soon as that patient's name is mentioned in like the multidisciplinary teams, everyone kind of sags and goes, oh God, not them again. Are they back? And so you can imagine what it's like for that person to be going into those services and kind of seeing eye rolling and like, you here again? you've not got yourself sorted out yet. And it's all about dumping the blame and the fault for not getting better on that individual. And it's kind of rough for them.
That's really sad.
Yeah.
So what makes it difficult to differentiate between DID and these other common misdiagnoses?
I think I suppose the simple answer for that with everything is that people don't know enough about the dissociative diagnoses. So the issue that is there is that people know loads about the other diagnoses. So it's really well known by schizophrenia, psychosis, even epilepsy and things like that, right? So people have lots and lots of experience, and there's lots of specialist services all over the world, dedicated conferences, all this kind of thing. And for DID, there's what, right? I mean, the doctors, the psychiatrists, the psychologists are not routinely being trained on those things when they are being trained, right? So by the time they qualify, they don't even know what DID necessarily is. So when they see a DID patient, it's not that it's being misdiagnosed, is they just don't know what they're looking at, but they're confused. But there'll be elements of that person's presentation that seem familiar. So I think what generally happens is like the psychiatrist, psychologist, or whatever are going, well, that looks enough like this, let's call it that. It's kind of like if you go out into the woods or something and you see a very, very large bush that's like 20 foot tall, you might think it's a tree because you don't know what bush it is. You go, well, it's 20 foot tall, therefore it's a tree. It can't be a bush because it's massive. So let's call it a tree. And then everyone just kind of agrees that it's a tree, and then everyone refers to it as a tree. It's like, oh, you go into the woods and you see that big tree in the middle of the clearing. And then someone like, let's say me or you both would go into that clearing and go, that's not a tree, that's completely different. Then you've got to change everyone's mind. And medical professionals are super reluctant to change their mind once they've made a diagnosis. They're very reluctant to say, actually, I made a mistake. It isn't that. And when you find them that do, it's kind of wonderful, actually, because no one minds that there's been a misdiagnosis. If you're willing to say, I thought it was that, I called it that. Actually, you've convinced me it isn't. You've done all this work, you've done the diagnostic profiling. You've convinced me it's not that. Let's change our tactic then. It's great. It just doesn't happen very often.
Yeah. I'm reminded of being in grad school, and I remember taking the trauma elective, and I remember like showing my professor Finding Solid Ground by Dr. Bethany Brand. I'm like, this is a book we should be using. Like I had already read the first 3 chapters. I was like, such great basic information. And the response was more like, oh no, that's for advanced studies. Like we're just doing basics here. But like, I think that's the misnomer, right? Like with the high prevalence rate that we do have with dissociative disorders, like it should be base.
I know, right? The numbers are there. The volume of people that are experiencing the symptoms is there. It's not. I think it's just purely. Well, I suppose for some people they don't want to diagnose it because they don't like the diagnosis. They're not interested in it. They kind of dismiss it as being a thing to start with. Then it's more just about not knowing enough about it, and there's a reluctance to take on something which seems, if you look at the TV and the film and all that kind of stuff, the impression of it isn't necessarily great when it comes to media portrayals, whether it's social media, film media, or whatever. It's just not particularly great. It didn't start great. I mean, we've got the whole Dr. Jekyll and Mr. Hyde thing going back to the Victorian era, and kind of that's a DID thing if you really stop and think about it. And, so everyone just sees it as being this kind of really weird, supernatural or strange construct. And when you map it according to what people have been through, it's certainly not. Obviously, it isn't supernatural, but this is so logical and it makes such perfect sense when you think about what people have been through. It's kind of weird for us to sit and go, why don't you get it? It seems really sensible,
Yeah. Yeah, I think we do have a tendency to pathologize normal responses to abnormal situations, for sure.
Yeah, we do, and there is that other thing, and I talked about this when I was in Ohio last year when doing like a whole day's teaching at Wright State University, which was a really beautiful experience for me. There's loads of people, and we're just saying part of it is just that you don't really want to walk towards the diagnosis, because that means walking towards why that diagnosis is there. And that's, for a lot of people, it's really unpleasant, and it's really difficult to fathom the darkness out there.
Yeah.
And I think there's a lot of people that just almost kind of deny causality. And so, like, if I sort of dismiss DID being a thing, I dismiss that actually there's a lot of horrible stuff going on out there in the world.
Yeah.
And it's a sad fact of this condition. It doesn't come from anything nice.
Yeah,
Right.
exactly. There's so much denial about what really goes on, and even as someone who has been diagnosed, like looking into it, it was like, these things could never have happened to me. But like, that is the whole point of the diagnosis, right? The point of having DID is to not know what happened to you.
Exactly.
To make it not be.
Yeah.
But,
Right.
yeah. It's I really like analogies and images and things like that. So I think one of the things that my patients always really appreciated is that we're talking about whatever topic, and you just come up with it, like the images and stuff. And I think it's like dumping nuclear waste in the sea, right? You can build this wonderful container, and you can cover it in concrete, and you can dump it at the bottom of the Atlantic Ocean, but it's not going to be there forever, is it? It's going to leak, and it's going to come out. Something is going to mean that all that stuff that's in there is going to come out and get to the surface at some point. And I think, the sort of trauma we're talking about is a bit like that. You can deny it and deny it and deny it as long as you like, but the leakage will happen inevitably. It's guaranteed.
It is.
Right.
So thinking about helping clinicians, kind of figure out whether or not DID is in the picture. Like when you think about some of these misdiagnoses that happen, like what are some of those overlapping symptoms that kind of lead people to call it, a tree when it's really a bush?
I mean, it's stuff like the internal voices. So that's a real classic one. I think the most common ones will be the people hearing voices immediately gets people sort of projected into the psychosis spectrum. Yeah. People having mood fluctuations without a lot of explanation or context often gets people thrown into the personality disorder territory. And then also, those mood fluctuations, the dropping of the mood and then sudden raising of the mood can get people into bipolar territory. And the kind of behaviors that people demonstrate, the sort of like the sudden shifting of behaviors. And sometimes it can be quite aggressive, because the best way to protect is to kind of, look aggressive, right? We've got loads of cats here, and when they get sort of stressed out or frightened, they kind of go big, and everything, all their fluff kicks out. And dogs bare their teeth when they're scared, and that gets you like antisocial personality disorder type stuff. So, I think, it's just those. And because they do exist, right? The mood fluctuations do exist. The voices do exist. The behavioral changes do exist. You look at all of those and go, yeah, I can totally see why the misdiagnosis has happened. It's not like they're being done on the basis of no evidence whatsoever.
Right.
It's just being informed that symptom that you're seeing might be something else as well, and consider it and rule it in or rule it out. That's all we ever say. Is like, we're not saying all of those diagnoses are wrong. What we're saying is there might be other explanations for it. And the better educated you are, the wiser you become in making your diagnosis, and you start thinking more about, should we just think whether it could be? And then let's assess for that. And that's the simplest thing. That's all we're ever really asking people to factor in.
That's perfect. Like I'm thinking back to grad school, like our whole chapter, we spent so much time on schizophrenia, but we didn't spend any time on dissociation at all, and if you don't know to look for it, then you're not going to pick it.
Yeah. And it's a flowchart job, isn't it? I mean, if you hear this arrow going down to schizophrenia, right? That's the basic training. I suppose what we're looking at trying to introduce is a different flowchart, which is like, if you hear this voice, there's one arrow that can point to schizophrenia and one arrow that can point to complex dissociation. And then there'll be a set of rules or things to consider to kind of checklist whether it could be this or checklist whether it could be that. So that would make the difference. And that's the simplest thing. it might be this, it might be that, and here's the constructs. Because the diagnostic criteria is so clear in a way, just add that other arrow, put a couple of things on it, consider this, tick or cross, and you'll get there.
Yeah.
It's awesome. Yeah.
Mm-hmm. So in your opinion, what's the biggest challenge clinicians face when working with dissociative identity disorder?
Do you mean like any clinicians or like the specialist-y type ones?
And there's an array of mental health professionals, right?
Yeah.
You have your licensed, mental health counselors, you got your licensed clinical social workers, psychologists, psychiatrists, So I guess that's kind of a broad question.
It is very broad.
Yeah. So okay, so I suppose, I mean, in terms of the challenge, I think it's trying to get the message across. So a lot of clinicians, and this is sadly, I think, a qualifications issue. So a lot of clinicians will consider the fact that it could be a dissociative disorder or some form, OSDD, DID, whatever it might be, let's say, and they might raise that issue, but they're not going to be heard because some professions aren't going to be taken seriously enough. So let's say to change the mind of a medical professional, you've got to have some status, I think. And I've seen this happen. Sadly, I saw this in work when I was in CAMS. The social worker was really trying to push the message, or whatever it was going on for this kid. They were trying to push this message. It's not that, it's this. And they couldn't really get anywhere. And the social worker said to me, can you just come along to the meeting and just say what I've been saying for the last 6 months? And I'm like, yeah, okay. I mean, if you give me a cup of tea and a few biscuits, I'll do that. That's absolutely fine. So kind of got bribed. I went along. I knew what she was saying was correct. I just didn't know why I needed to be there because I was kind of a bit naive and a bit fresh at the time. So I went to the meeting, introduced myself. Hi, Dr. Lloyd, blah, blah, blah. And they said, what do you think's going on with this kid? And I kind of scripted out exactly what the social worker had been saying. And at the end of that meeting, they all accepted what I'd said and changed the plan for that kid. And I walked away thinking that was kind of sad. And the social worker was like, thank you so much. And I'm like, I should never have had to do that. You were right. But it was like simply my doctor status as being a clinical psychologist sort of just trumped the room in a really sad but useful way. And I think that's a big problem because you've got a lot of therapists, you've got a lot of counselors, you've got a lot of, say, CBT therapists, you've got a lot of psychotherapists. And I think they will be seeing this, but they might be able to help that individual, but they can't change the system. And let's say if they have to fill out an insurance form, it may be that their qualifications are not enough. Or if they need to go off to one of these big companies that sell all the assessment tools, it's like your qualifications aren't even going to give you access to some of the assessment tools that you get when you're a doctor. And so there's that, right? And that's like a threshold thing that I think a lot of people have. You've got to try and convince people that this diagnosis means something for it to be a gateway into therapies and funding, insurance or NHS type stuff, whatever it might be. You've got to change people's opinion, and in order to do that, you've got to be taken seriously. You can't just batter the door down and demand that people accept the diagnosis of DID, because they won't. It's just the sheer facts of it. You can present all the arguments, all the evidence, but unless they're inviting you and you're being welcomed as a guest in that arrangement, they're not really going to hear it. You can't force that diagnosis at people. So I think that's kind of the main ones. The other one is that people want to get into it, but they might not know how. They might not be able to access the right training. I think supervision is a massive problem. So a lot of people would like to do this work or are doing this work, but really struggle to get a clinical supervisor to really look after them in that journey, which might potentially invalidate insurance and things like that. Because if you're working without supervision, it's kind of slightly risky. And there's not enough people doing this. There's not enough people training people in doing this, and there's not enough people supervising the work and looking after those clinicians when they are doing it. You put all of that together and you're not even in the territory of it's really hard. This isn't easy work. This is really kind of, like I was suppose saying that denial thing, this is an entry into some real darkness about the world and some really grim, sad, awful stories that people have. And some people will be like, well, I can get paid to do that, or I can get paid exactly the same rate to work with people who are scared of cats. The hourly rate might be the same, and you're like,
Yeah,
you can
it
throw
is.
yourself into this, and you kind of get dragged into a person's world, and the strangeness of the whole system and the setup. You might be spending years and years and years really fighting to get anything done, where you can have a much simpler job over there doing what I would consider to be the fairly straightforward everyday kind of stuff. It's super important, but it hasn't got this complexity.
Yeah.
So I think some people just look at it and go, it seems really, really difficult. Don't want to do it.
Yeah.
That is true. Yeah.
So having people with a passion for this
Mhm.
specifically is the hard thing for sure.
Yeah.
It's the system. So
Yeah.
system needs some work. Right. So thinking about being able to recognize it. So let's say we've got a clinician that at least knows to look for dissociative identity disorder, that's aware that, this is a real diagnosis to consider,
Yeah.
they have a client there, and like, what's going to be a sign that their client is actually experiencing a switch between themselves as opposed to someone who's just experiencing a mood swing? Like, what's going to set off that flag that they need to do some further assessment?
It's a really good question. I guess in a way, amnesia is sort of an easy one, whether the person even knows that they've done it, which relies on you seeing this thing and, the kind of the observation of that person, because some of the switches are so subtle. They're really not all that obvious at all. So some people can have a really obvious switch, and I've heard some stories where like someone switched and the therapist has almost fled the room, just like, I can't handle this. This is not a thing. I think it's being able to notice that something has happened, and it's about, I think if you're prepared, that's probably the thing, because I think a lot of people see switches and don't know what they're seeing, so they dismiss it as mood swings or fluctuations in fatigue, tiredness, and those kind of things. I think if you're prepared and you know kind of what you're looking for, you're more likely to see the switching. You're more likely to reference it. Mm-hmm. And I think when the potential switch happens, the clinician like myself or our team would stop and we go, did something happen then? Am I still talking to Jane or Steve or whatever? And it's like something, and the person might be none the wiser. And you just stop and go, has anyone ever said what I've just said to you before? And they'd be like, yeah, people say that all the time. I've no idea what they're talking about. It always makes me feel a bit strange and a bit wobbly. And you get into this slightly different conversation that you just don't when you're talking to people about mood changes, because they are aware of everything that's going on. Mm-hmm. So it's like I think the key difference is that the questions that you ask to someone who's experiencing lots of mood changes, you get lots of really obvious, clear answers. They might not know the reason, but they know that what's happened. Yeah, it happens to me all the time. I don't know why it's happening. And then with the sort of the more DID, OSDD stuff, when you see that kind of like that difference and the emerging thing happening from the inside, you get a very, very, very different sort of answers.
Yeah, it's so like, it sounds. Mm-hmm.
I was going to say, like, because we do the SCID-D, so the full like structured clinical assessments and things. If you ask those questions of somebody who is, say, bipolar or some like cyclothymic personality issue, something like that, they just don't really know what you're on about when you ask those questions. They just don't apply. Mm-hmm. So when you ask them of someone who's got OSDD and DID, even if they're deep in denial, those questions make sense, and that you get very, very, you start getting these really articulate answers that people are, or they feel something in response to the questions that isn't done with almost anybody else.
Yeah, that's interesting to know. Kind of like what I'm picking up is there seems to be like a layer of amnesia or almost an awareness of amnesia when trying to answer the questions for you.
Yeah. And that's, I think, because amnesia is so absent in most other stuff. Once you've factored out the head injury, the alcohol, the drugs, and those kind of things, you don't really see that amnesia outside of like organic medical services. So like, early onset dementias, Alzheimer's, stuff like that. Fine, you'll see a lot of dementia within that. And people who've got like low cognitive abilities, there'll be a lot of forgetting, which is different from amnesia as well. But in traditional mental health services, and I've worked in traditional mental health services for years and years and years, there was really no amnesia. It was forgetting through stress and anxiety, but not amnesia. So when we actually look at the amnesic qualities that are present and that are going on, we see all our stuff present within that. So I think amnesia really is at the core of a lot of this. Not everyone has amnesia, like in the big way, but I've never diagnosed anybody with DID or OSDD who hasn't got amnesia in some form or another that is different from what I would call just ordinary forgetting. So it is
like that micro amnesia that can happen.
Yeah, that can't be explained.
Yeah,
it's not like losing your keys. It's just
right.
Fine. That happens to me all the time. I mean, I lose stuff here all the time. None of it is about amnesia. It's just forgetting. And those are very, very different qualities.
Yeah. Well, thank you for sharing. Yeah.
Right.
Good. Hi, dear friends.
We hope you're enjoying the episode so far. We'd love to invite you to join Hearts Multiplied, our private online community for people living with a dissociative disorder, along with separate spaces for clinicians and supporters.
Inside Hearts Multiplied, we host live events just for you, including social hangouts, little story time, teen D&D campaigns, online gaming like Minecraft and Mario Kart, and vibrant message boards on topics like intimacy and OEA.
We also offer a supporters group and a clinical consultation group for therapists working with dissociative clients.
And We Garden System facilitate 8-week peer coaching groups where we work on internal communication and personalized healing goals.
To learn more and sign up, visit acoupleofmultiples.com. We'd love to have you. So when should a clinician consider a dissociative disorder when assessing clients?
So I would love it if they considered it all the time. So, I mean, it's
a great answer.
I mean, just why not consider it? I mean, I advocated when I was in the NHS, I advocated for us to use the screening tools with everybody who came through reception, because it would at least give them something to do while they waited. So people rock up to reception, they give their name, they'd say who they're going to see. The receptionist says, take a seat. You've got anywhere between 5 minutes and an hour, depending on where you are, whether it's like medical services, outpatient clinics, mental health settings and stuff. If most people arrive pretty much early or on time, and occasionally they have to wait 5 to 10 minutes. I don't let people wait, but if someone turns up for me like 5 to 10 minutes early, why not give them this bit of paper and say, why don't you just fill this out? It takes like 10 minutes. It's not really triggering. You might think it's an absolute waste of time and just go, this is meaningless nonsense, in which case you're kind of screened out. But what's the harm? And something like the DES, right, the Dissociative Experience Scale 2, takes about 10 minutes to fill that out, takes about 5 minutes to score it once you've got it. But the information contained within it would just change the nature of mental health services. So
really would.
To everyone who turns up for a mental health clinic or an epilepsy clinic or a pain clinic, give them the DES. And then, because you don't have to really even be trained to work the answers out. You just count the numbers, divide by the number of questions that were answered. And if that number is over 30, something's going on.
Yeah.
That's it. That's all it would take.
That would be great. So now that we're kind of getting into some assessments, so you mentioned the DES, you've mentioned, I think, the SCID-D. So can you kind of go over a little bit more about what are some common assessments used to screen for or assess for dissociative disorders, particularly dissociative identity disorder?
Yeah, I mean, the DES is a good start. I mean, we always add the somatoform dissociation questionnaire to that, which is called the SDQ. So that factors in the physical nature of things, thinking about conversion symptoms. So those are the sort of the industry standard, really nice, easy ones. But there's a number of different things like there's more detailed stuff like the MID, the Suzette Boon's, the TADS, Marlene's SCID-D. So there's a number of these different things on the marketplace. And then you've got all the trauma questionnaires. I like the trauma symptom inventory because that factors in all sorts of aspects of PTSD, complex PTSD, and trauma and the dissociative things. It doesn't really matter. I mean, it's a case of, you can screen, you can do all these things. I think if you've got the DES, crack on, because that's the simplest, that's the easiest one that you can do. The more important stuff is just the being kind of trained and aware of what you might see when you're actually working with that person, is to listen to what they're saying. So the nature of the assessment process that we do asks those kind of questions. It talks about lapses. It talks about, oddities or any strange experiences that you might have that can't be easily explained. But also listening to the history of the patient. So if someone comes to you and says, as you both sort of like did at the outset of this, if 4 or 5 different diagnoses, it's about stopping and going, well, I wonder what's happening. It's looking at the treatment history as part of the screening. So the nature of the assessment that you do, you can bring in different tools, and there's ESTD has got some really great ones on their website, and ISSTD will have all, various different things. So whatever tool you use is great for getting numbers to see what's going on. But you always, the best route is to sort of have that knowledge of the patient and be able to just look at them and go, okay, you've bounced around the system. No one's really been able to get a handle on you. You've picked up all of these diagnoses. Let's stop and rethink is the ultimate best strategy to take.
Awesome.
Yeah. So how can clinicians prevent misdiagnosing a client?
I don't think you can. I don't think you can prevent misdiagnosis. I think kind of what I said earlier, I suppose, is you'd be willing to be wrong. And I that's what I would prefer, because you always, false positives and false negatives will occur in all aspects of mental and physical health. That's simply the case. I mean, we've got a cat who's been treated for a lymphoma for the last year. And the vet was absolutely certain this cat had a lymphoma, big lump on the neck and all this kind of stuff. Took a biopsy, did all this stuff. Yep, it's lymphoma, it's cancer. And, the cat's been on sort of steroid treatment. And a year later, there's 0 symptoms. There's no mass on the neck. And the vet who we took that cat to, who's been looking after this cat, has said that's probably the best case example of a misdiagnosis I've ever done in my clinical practice. And we were relieved, because it meant, brilliant, that means our cat probably doesn't have lymphoma. He was just like, he needed a load of dental work and he had an abscess for some reason or another. And he'd had an operation, his immune system was compromised, and this abscess kind of got bigger than it should have been. And it didn't really respond to the obvious antibiotics in the right way. So the vet was willing to turn around and go, I think I was wrong, and I'm really glad I was wrong. The treatment didn't hurt him, but it gave us it freaked us out and scared us for a whole year. So I think, that vet being willing to say, I think I was wrong, that's what I want. I want, people are always going to get diagnosed with lots and lots of different things until they get to the right one, certainly in mental health. But when you do get to the right one, make it the right one. Yes, and don't keep holding on to all the ones which clearly are not right. So don't just say, yeah, they have got, bipolar, they have got schizoaffective disorder, they have got borderline personality disorder. We'll just add DID to that. Wouldn't it be nicer to just clear the table of all the stuff and say, why don't we just have this as the primary diagnosis and then focus all our efforts on trying to help the person with that? So, we can reduce misdiagnosis through just education and training and practice and supervision. That's simple, but we'll never take it away. We know that we might be diagnosing some people with DID who might not have DID, because we've only got, let's say, 4 or 5 hours with that person, and we've got all the screening tools, we've got the detailed structural assessment and things, but ultimately we're only going on a snapshot of what that person is giving us. And sometimes we might get it wrong, because they may be convinced they've got something and they might not have it. And at the same time, we know that we diagnose quite a few people with OSDD when it turns out, like a year later in therapy, that it is DID, but it was so hidden, it was so protected, that the best we could get to it was OSDD. And the patient is like going, I don't want it to be OSDD. I don't want this. I don't want this. And they're heavily pushing away that diagnosis. And we managed to convince them that it is OSD because the evidence points to it, we get them into treatment, and then within a year or so of treatments, the parts that were always there feel safe enough to start emerging through the therapeutic process. Then we can then turn around and go, we're going to upgrade that diagnosis to DID. So,
Yeah.
I suppose, I hope that answers your question, Drew. Okay.
Absolutely. And I think that's really important for the clinicians listening to hear, and psychiatrists and all of that is it's okay to be wrong.
Yes.
Yeah.
And
you just
figuring
fix
out
it.
what it is making you a good one. So
yes. We can't be perfect. I mean, we don't really have the biological markers that say, diabetes can have, or cancer can have,
Right.
kidney failure or lung function tests. For asthma, we don't have those biological markers yet. They are knocking around, but we don't really have them yet in everyday clinical practice. I can't screen my patients with an MRI scanner and then look at the imaging results and know what on earth I'm looking at. I just can't do that. And the expense of getting that in would be horrendous.
Right.
So we don't have that absolute certainty. We can only go on our best judgment. And sometimes the information that we need to go on that path or that path is just not available. But being willing to say, we need to change this. That's all, right? So I think I think a secure clinician, it feels like a securely attached clinician should be happy to say, I'm willing to change my mind on that. Mm-hmm. It doesn't seem that hard.
Yeah. Okay. So now, thinking that we'll have clinicians listening, and learning about DID, and then they'll start recognizing DID in their clients, but then they have to deal maybe with a supervisor, right? So how should clinicians handle working under or even working with supervisors or other mental health professionals that still they don't believe in DID? They think it's not real.
You mean like if you've got a supervisor and you say, I've just taken this person on, started seeing them, I think it's DID, and the supervisor's like, nah. Do you mean like that, where they're just they're just missing it completely?
Yeah. I had someone consult with me once, and they said their supervisor rolled their eyes and said, don't you know that's not real?
Oh, yeah.
Yeah.
Okay. I mean, so what should we do realistically with that? I mean, should we be trying to change the mind of the supervisor? I mean, that would be the nicest, the biggest win. So can that clinician turn around and go, well, it is. So I'd really appreciate if you were open-minded with that. Mm-hmm. I think there's potentially a dialogue can happen. I mean, I'd hate, I think if it feels like it would be a bit of a shame if that clinician just went, then I need a different supervisor and walked off. Mm-hmm. Because the supervisor they leave behind isn't actually going to change.
Right.
They're just going to go, well, I'm kind of glad I got rid of that person. They were bringing me a load of crazy stuff and I don't have to deal with that. I'd like them to be able to engage with the supervisor and show the evidence and say, I get it. I'm totally fine with the fact that you think this is all nonsense, but let's look at the facts. And if your supervisor is coming from a place of science, the facts are there. Mm-hmm. And it's kind of indisputable, some of these facts. And, even if the supervisor says, well, they might be making it up. It's like, people make everything up. Why is DID different? Why doesn't have some sort of special place in the world for making stuff up? I mean, there's people that have been making up every condition under the sun for whatever gains that they might get, right? Sympathy, money, status, I don't know, comfort, reassurance, care seeking, whatever. People make stuff up. So DID is fine. There'll be certain number of people that make that up. And there's a certain number of people that make everything else up. I'm not really bothered by that. I think it's more about saying to the supervisor, I really believe it is, and I'd like you to listen and take me seriously. Respect that I'm not stupid. And you've been, you and I have known each other for a long time. Hear me out. Let me present the evidence and present the formulation, which is something that we really work with a lot in clinical psychology. And I know that some therapists don't really have that training in the formulation process. And it's a really important process to have. And I think if you've got a supervisor and you say, let me demonstrate the formulation, let me present this client, Let me talk it through. Let me give you my ideas. Let me show you the evidence that is there. Then we'll discuss, and maybe there's some change to be had. That's what I'd rather would happen.
I love some of those phrases. I think that will be wonderful because I get questions like this all the time, like they come to me and they're like, nobody wants to hear me out, so I think those are some great phrases to use.
Yeah. And it can be done. I mean, I did some psychiatry training a few years ago, and there's like a room full of psychiatrists, and a couple of people were eye rolling and saying, yeah, this isn't really a thing. And I was presenting all this stuff on DID and they weren't really all that interested. And so I just kept at it because it's just, I just did the presentation as I needed to present and finished, and it was great. And I got some really nice feedback. And then about a month later, one of the eye rolling psychiatrists emailed me and said, I'm really sorry. Actually, I was kind of rude on that training. And, I wasn't really paying attention. I was kind of dismissing everything because it just seemed so, out there. But I've just had a patient admitted to the ward that I lead on, and their symptoms entirely matched everything that you were saying. And I think this might be a case of DID, and I'm willing, and I'd like you to come and help me understand it. And I was there like a shot, and it was like, it was so wonderful because I knew that she was that supervisor who would have said, nah, not having it. This is nothing. And then, but the awareness, something about the message had crept in. Then when she saw that patient on the ward, and she's sort of like, how, that's exactly what literally this person is doing exactly what Mike was describing. Maybe there is something in it. And I think that psychiatrist, that's probably about 7 years ago now, something like that. I think that psychiatrist in the last 7 years will have seen more cases of dissociation and would have worked brilliantly with them. So there is always a win to be had, I think. If we just
right. That's
very
wonderful.
good.
Okay, so in your opinion, what is the most important quality or skill besides the therapeutic relationship a therapist can develop to successfully work with clients that have dissociative identity disorder?
Well, I think just being a good therapist. I think just being really centered and in touch with yourself well. So not being massively defensive or, locked into a particular way of thinking, not what we call it pigeonholing people into into what you like doing. So everyone's got to fit into this. I think just being really open-minded and therapeutically attuned and willing to not be the most, not be the expert in the room, willing to not have all the knowledge, to sit, because you're right, the therapeutic relationship is the key construct. Once that's out of the way, it just comes down to just you and your skill set and what you bring in the room. And I know that things like psychoanalysis can get kind of trashed in lots of different settings, but I'm a big believer in the sense of the self and the therapist being tuned into themselves and having that kind of transference, counter-transference type facility available to them, where they can feel their own changes according to what's going on, and to be able to pick up the messages. Because there is something really interesting about DID that feels physical in the space that I've not encountered in anywhere else. I've worked with people with all sorts of different mental health conditions, and I've never really felt the arms on my arm, the hair on my arm sort of stand up in that kind of electrical way. Even when I've been scared, all that's happened is my heart's gone up and I wanted to get out of the room. You might be in a room with some violent people kind of thing, but the stuff that goes on in DID really kind of really gets something here. And I think if you're willing to be open as a therapist and willing to be wrong and willing to not have anything and willing to just take some risks and make some mistakes, and you have that security, you have that protection, you're well looked after as a therapist of whatever type, I think that is the thing. It's just really knowing who you are and being there for the right reasons, and just be willing to sit there with the other person and go, neither of us have the faintest idea what's going on, but we'll be okay. I think that counts for a lot, and I talk in my training about the gut, that being one of the most important therapeutic skills that we've got is listening to our gut. And when that is changing and that's jumping all over the place and it's kind of freaking out down there, is to be able to say to that person, what is going on? Because I was fine when I came into this room, and 10 minutes in, I feel kind of really freaked out. What's going on for you at the moment? Because something's happening in this room. I think that doesn't feel like a particularly highly skilled thing, but I don't see it being done enough. And I would like that to be done more.
True. Yeah. Like focusing on the energy.
Yeah. Energy is so important.
It is an energy thing. It really is. And not in a, we don't have to be spiritual about it. We don't have to be, it's not like a religious or a spiritual thing. It is purely, there is an energy that is created by people. And I've always felt that, when you meet someone for the first time, you can sort of feel that you've met them forever. And it's like, wow, it's like you just immediately tune in. And there's some people you just like, you meet them and then you just want to be gone and you want nothing to do with them. Whatever is going on between people, I think a good therapist can sit and listen to it, can share it in a meaningful and compassionate way, not in a blaming way. You don't want to say, God, 10 minutes with you and I feel awful. That's not the way to do it.
No.
It's 10 minutes in and I'm experiencing a load of stuff that I don't quite understand. And I'm wondering what the last 10 minutes have been like for you. If this is what I'm feeling, and even if the person can't get their feelings, they might be autistic or they might be really depersonalized and their feelings are just not, they'll know that something is going on. They'll be tuned into that, because what we do know about complex dissociation is that scanning takes place at some level, and even if it's not taking place at the front, I mean, you're nodding, right? You know this. So it's going on. It's going on. That scan, if something is shifting and something is changing, there will be some element in that system which will be picking it up. Yeah. So we just connect with it. I mean, that's the thing.
Very good. All right. So how can clinicians learn more about working with dissociative disorders?
Okay. Watch my YouTube channel. So I'll plug that. I'll happily plug that.
Please do.
Watch your YouTube channel. Listen to your podcast, right? Get the information that's accessible. The beauty of this is it doesn't cost anything. I mean, you can go to conferences. I mean, I go, the ESTD conferences, ISSTD conferences, right? Sort of big ones, the big traumas. They can cost thousands and thousands of dollars once you've got the flights and the accommodations, and they're usually in really cool cities and really cool hotels, and you haven't even factored in, what you have to spend in the restaurants and all that sort of stuff. So super expensive. There's great training out there, and some of it is very expensive. There is awareness training, which is what we're providing, which is we're not able to really go into detail about case type stuff, but we can get into depth of material. We can share evidence. We can make it accessible. And I think there's that. There's obviously some fantastic writers out there that are producing brilliant books. And you've mentioned Bethany Brand already. I'm a big fan of Bethany. I know her. I've spent some great time chatting with her. Suzette Boone is another person who just produces such wonderful, accessible materials. There's great textbooks. There's loads of in-person expert by experience testimony books out there. Some of it's kind of scary in terms of what people have been through, but I suppose and it's not about being a library. I've got loads of books on my shelf here, but I don't consider myself to be a library. I mean, I don't have detailed knowledge of all aspects of trauma and all aspects of dissociation, but I'm willing to learn. And I'm one of these people, I learn by my questions. So I see something, I don't understand it, I go and try and find the answer to that specific thing. And once I've got that answer, it kind of gets locked into my head. Mm-hmm. So people just sort of find really good material. Good supervisors can help because you learn through those conversations. But the best learning about dissociation is to be in a clinical space with someone who is dissociative and work with them in partnership and collaboration, not to come at it like I'm the guy, I'm the professional, I know best. It's just to be two people in the room going, like, we're just going to figure this out. We're going to learn from each other. That's the best learning that I've ever had, is the hours spent in the clinical room with people with this condition. The beauty of it is that it makes everything else easier. I think if you get really good at working with complex trauma and dissociation, you're automatically better at everything else, because this is really high-end stuff. So yeah, listen, learn. It's simple, isn't it? Gosh.
Yeah, and this is where I really kind of want to plug the Healing Together conference again. We go to this conference every year, and it's because you get to be around people that have DID, their supporters and clinicians. Like, all populations come to this conference, and just kind of immersing yourself so you can recognize, what is it like? Once you get to know somebody that has DID and recognize what that switching looks like, how it shows up, like, then you're going to recognize it.
Yeah. And it's going to be wonderful to join you, because all things as it stands, I'm going to be there next February in Orlando, and I'll be at that conference with you. That'll be wonderful.
So exciting.
So another reason to come to the Healing
Another
Together
reason,
conference.
yes.
Absolutely. It is true. And this is what was really nice when we set this thing up with Front Porch Counseling in Ohio. We set this sort of day in Wright State in Dayton. And we had the room full of, there were people with dissociative conditions. There were students of psychology from the university and trainee therapists there. There were the supporters of people with dissociation, and there were experienced and new therapists, all in the same room, all interacting with each other, all talking, all meeting. And it was just a wonderful, wonderful experience, because it just brought in everybody who had an interest in this field, all in the same place. And it was so nice and friendly, and people were sharing lunch and talking, and it was just a wonderful experience. And it just, all the barriers went down, and people just had a very, very relaxed and calm day. Hopefully learned a lot through my waffling on the stage when I was doing the lectures. But ultimately, I think what really people got out of it was just that sense of there's like a community to be had, as it were, and just not being afraid simply because someone's got a condition. You don't have to be afraid of it. I think the interesting thing was people probably couldn't tell, who's the students, who are the lecturers, who are the therapists, who are the people with dissociation, who are the partners of people with dissociation. When you looked at people, you couldn't tell, because it's not like it's a uniform or anything, is it?
Right.
So it was a really nice open day. And I guess, the conference, the Healing Minds, I guess that's going to be exactly the same, isn't it?
We're at a point now where people have multiple hats now, like, we are a supporter of each other.
Yes.
I am a registered mental health counselor intern now. So, like, I do the therapy work, and I have DID.
And you have it.
Right.
Yeah. Right.
Yep.
It's possible, isn't it? It can be done.
It is.
Yes. Yeah. I love how open you both are about it, and just, you're putting yourselves there, and you're doing all that awareness raising, and you're using yourselves, your thoughts, your experience as a platform to do it. It's fantastic.
Thank you.
Thank you so much. So I know you've mentioned your YouTube channel. Where can people follow your work?
So, I mean, that's the main thing. So the thectadclinic on YouTube, and we've got over 200 videos on there now. I think we're close to something like 22,500 subscribers, which I think is amazing. It's just absolutely fantastic for what is essentially a highly focused kind of niche sort of field, realistically. Yes, So, and the community that's within that, so people read, the comment section is a fantastic place to learn about dissociation. So we put things on there about work that we're doing. We've also got the website, which is CheshirePsychology.com. So the thectadclinic is embedded into that. We've got a webinar. I'm doing a free webinar next Monday evening. So like your time, kind of 1 o'clock in the afternoon, I think. Going to be producing some webinars over the autumn as part of sort of like a series of different things. I'm practicing doing a live Q&A this evening. So after this, I'm going to be doing that on the video. That's going to be, I don't know what that's going to be like. Who knows? The only ones I've ever seen doing that are like folks who do it for NFL games. So like the game's on, they're doing like a live streaming thing when they're watching it, the teams and things. So I don't know what it's going to be like. So I think, follow the YouTube channel and follow the website, our main kind of portals for the work that we're doing. We're trying to make things cheap and accessible and good quality. and that time scale. So I'm kind of doing more things in the evening so that the folks in the US and Canada can access it. Because if I do everything when I want to do it, you're all in bed. It's like
I know, right?
in the morning, and it's like 3 a.m. for you or something. It's like it's no good. So those are the main things, and to leave comments and share and leave ideas. I mean, a lot of the YouTube channel has come because people have said, I really want to know more about this topic, and that's a really great idea, and then I'll make a video on it and I'll say thanks to so and so for sharing that topic, or we'll just have like subscriber questions and I'll just do a video on it. So, and there's a lot of stuff about cats and ducks and our therapy dog as well on there, so we have
perfect. So what is one last thought you would like to leave for our audience today?
A last thought for the audience. Okay. I guess it's enjoy this, because there is, and I'm really glad to see both of you smiling, and there's big grins with this. This is really hard. It's obviously hard having a condition, right? So I'll start with that. There's whatever therapists might say, oh, it's so difficult. It is not as difficult as having this condition. That's super difficult, right? The effect that it has on life. So it comes from a place of suffering and sadness and fear and powerlessness and all of that. The work is really hard. To get good at this, to get experienced at this, takes years and takes real investment in time and money and resources, all these kind of things. So there's a whole load of hard work that's going on all over the way. But it's good fun. It's really enjoyable work. We don't laugh at the reasons for it, but we laugh at the circumstances, and we laugh at the strangeness of it all, and the odd situations and the odd reactions and the weird interactions that go on the inside, and the strangeness of the outside world. And as therapists, we can sit and we can have sessions with people that are really super serious, but also we're having fun and we're laughing. And I've never really had as much fun in therapy as with dissociation, because there is something about it which just is, we have to smile because it's just so awful otherwise. So I think the biggest thing is not to be frightened, to enjoy therapy, to take it seriously, to do all the hard work, but to find the space and find the time for smiling and enjoying the process, and enjoying the learning and enjoying the fun of it. And I've had many times in therapy where I've been working with someone, let's say on a really specific thing, let's say denial, right? Let's say a person is denying. The folks on the podcast won't get all of this, so you have to watch the YouTube thing because it's a visual thing. So we'll be talking about, every time someone denies, we say, look, you're doing that again, Jane, you're doing that denial thing again, right? And then eventually get to a point where then the person is kind of coming up with that denial statement, and all I'll do is this. And they instantly
the look.
Everything. They've got that look thing, the whole Roxette thing. You've got the look. And sorry for the podcast people, you just missed out on that one. And it's funny, and we kind of just start laughing because it's broken all the tension, and we've identified the pattern that's been taking place, and that sequence of events is there again. And instead of just being all cognitive about it, we just make it a bit more of that like human interaction, like I would do, just like you're doing it again. And it just, all the tension comes out of the room, and we laugh, and that learning about that. And it's so much fun. And, I think, that would be my thing. Enjoy the work.
Yeah. Yes. I mean, it's real. Like, we are not as scary as you think we are.
Yeah, right. Absolutely.
All right. Well, thank you so much for taking time out of your schedule to be with us and share this very, very important information. It is so desperately needed.
Brilliant. I've really enjoyed it. So thank you for reaching out and, getting in touch and getting all the questions prepared and working with me and everything. So brilliant. Yeah. And we'll, all being well, we will meet up in Florida next year.
Yes, absolutely. All right.
Which would be great. So, and all right.
Awesome. All right. Thank you, dear listeners, for hanging out with
A Couple of Multiples. Today's episode is brought to you by
Healing Selves Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Healing Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Healing Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid, and Medicare. This episode is brought to you by Donna Earle, a licensed professional counselor and certified clinical trauma professional.
She's the founder of To Life Counseling in Southlake, Texas, where she helps individuals ages 17 and up heal trauma, navigate identity, and reclaim inner peace. Her trauma-informed approach includes EMDR, parts work, strengths-based therapy, TBRI, and CBT.
She's passionate about honoring the resilience of the human spirit, one story at a time. Thank you, dear friends, for spending time with us today.
We're so grateful for each of you and all the important work you're doing. Whether it's supporting others or navigating your own healing journey, we hope this episode brought insight, encouragement, and something new to consider.
If it did, we'd love for you to share it with a friend, your therapist, psychiatrist, or colleagues. It's one more step toward changing how the world understands DID.
And just a quick reminder, this podcast is for educational purposes only and is not a substitute for therapy. Listening does not create a therapeutic relationship with the hosts or any guest speakers.
Until next time, take gentle care and thank you for hanging out with
A couple of multiples.